Hi, welcome back to IU Radiology Case of the Day. My name is Tim Tsai, and I'm a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting abdomen case. I'd like to give a shout-out and thanks to Dr. Tan for his help, and of course to Dr. Kuntz for organizing the entire Case of the Day initiative. Just a reminder that all of the content in this presentation has been fully de-identified to protect patient privacy. Here, we have a 35-year-old patient with left upper quadrant pain. Here are the images. From left to right, we have the axial, sagittal, and coronal contrast-enhanced CT images through the abdomen. Take a moment and have a look. Alright now, what are the findings? What is your differential for this case? And what is your diagnosis? Let's go over the images. We see that there is a large, multiloculated cystic lesion of the abdomen. It looks very closely associated with the psoas muscle. This mass appears distinct from the kidney and ureter, as there is no claw sign and the fat plane appears intact between the kidney and this lesion. We see that this mass is not really part of any structure, certainly not pancreatic or bowel in origin. This is a case of primary retroperitoneal mucinous cystadenoma. These are rare primary epithelial tumors of the retroperitoneum. There are multiple competing hypotheses regarding its origin. It may be secondary to invagination of the peritoneal mesothelium with mucinous metaplasia and cyst formation. It may be from ectopic ovarian tissue. It may be from a teratoma. We're not too sure. Ultimately, the masses become symptomatic once they've attained adequate size to cause mass effect or obstruction of adjacent structures. Imaging will reveal a homogeneously cystic retroperitoneal mass that is usually unilocular. Primary retroperitoneal masses are fairly rare. However, up to 80% of retroperitoneal masses are malignant. Tumor markers and imaging findings are not specific enough to exclude malignancy or make a confident diagnosis. Aspiration of cyst contents also frequently fails to reveal the type of epithelial cells lining the cyst. Other entities can have a similar appearance. Differentiation from a mucinous cystadenocarcinoma is difficult on imaging alone, and while the mucinous cystadenoma is unlikely to recur and behaves in a benign fashion, mucinous cystadenocarcinoma can recur or metastasize. Cystic mesothelioma occurs more frequently in women, is not related to a prior asbestos exposure, and while it does not metastasize, it can recur. Cystic lymphangiomas occur more frequently in men of any age. It's multiseptated, and it crosses more than one compartment of the retroperitoneum. Imaging does not reliably distinguish between these entities. Non-pancreatic pseudocysts can also have a similar appearance, but have a more thickened fibrotic wall and contains hemorrhage, pus, or serous fluid. Cystic teratomas are more common in newborn females and contains fat and calcifications. Cystic teratomas are more likely to be benign compared to solid teratomas. There are a host of other types of sarcomas such as liposarcomas, fibrosarcomas, leiomyosarcomas, malignant fibrous histiocytomas, and rhabdomyosarcomas. Ultimately, they should be surgically removed with care to prevent spillage of cyst fluid. For more reading on retroperitoneal masses, I'd recommend this paper. So in summary, primary retroperitoneal mucinous cystadenomas are rare lesions that appear homogeneous and cystic and usually unilocular. They are typically asymptomatic until they cause sufficient mass effect and obstruction. Differentiation from malignancies is difficult, so they should ultimately be treated by surgical resection. So as always, thanks for tuning in to IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz, and you can check out our complete collection of Case of the Day materials at the link below. Thanks so much, and have a great day.